Hi, my name is Randy Beckett. I'm a psychiatric nurse practitioner, and for the last 7 years, I have practiced pretty exclusively in long-term care facilities, skilled nursing facilities, assisted living facilities, and most recently at an inpatient at a facility at a state hospital. So one thing that we all face in these different facilities is resident-on-resident aggression. And this is a difficult situation because not only are residents injured and traumatized, but then also it is tough on the staff because we have to report these issues. So we're going to do a series of videos. I'm going to keep them relatively short and cover different aspects of resident-on-resident aggression and cover several topics. So resident-on-resident aggression is defined as negative and aggressive physical, sexual, or verbal interactions between long-term care residents that in a community setting likely would be construed as unwelcome and have a high potential to cause physical or psychological distress. So obviously the best way to handle resident-on-resident aggression is to prevent it. So I'm going to talk about the situations and the kind of attributes or characteristics we find in residents who are involved in resident-on-resident aggression. So one thing that comes out in the literature is that they tend to be male. And although I guess if the research says it must be true, but I've seen a significant number of incidents on resident-on-resident aggression involving females. So I don't think that that's a good criteria just to set out and say, okay, males are more likely, because females are very likely to be involved in resident-on-resident aggression. A very significant attribute or characteristic is people with pre-existing mental health issues. Obviously, we have a lot of people in long-term care facilities now with psychiatric problems, and these psychiatric problems can lend themselves because of delusions or hallucinations or traumatic brain injury, often to very difficult behaviors and a possibility for resident-on-resident aggression. The other thing is that there is a likelihood resident-on-resident aggression in people with cognitive impairment. People with cognitive impairment wander, they go into other people's rooms, they get into other people's belongings, they might touch other residents because they're confused and they don't know what they're doing, or they may say something to other residents, and of course they can have delusions as well and behavior problems. So that's something to really watch out for and to help prevent resident-on-resident aggression is to recognize that people with mental illness and also with cognitive impairment or traumatic brain injury are very likely to be involved in resident-on-resident aggression. Now, what are the injuries that occur? A lot of times it's lacerations, bruises, fractures. People get pushed down, people fall, they break their hip, They have head injuries from falling on their head. And a lot of times these resident-on-resident aggression incidents occur in patients' rooms because a patient wandered into another patient room, but also hallways, dining rooms, common areas are common places for resident-on-resident aggression to occur. So one thing about people who are involved in resident-on-resident aggression is they tend to be more physically independent. So a perfect situation is a person who is physically independent, can walk independently or walk with a walker or even self-propel in a wheelchair, but is very cognitively impaired. So they may walk into or self-propel in a wheelchair into another person's room, but they're very confused and they don't understand what they're doing. They don't understand. I mean, you find residents in somebody else's bed because they don't know that it's not their bed. So it's not uncommon for these people who are mobile, independent with ambulation or in a wheelchair, but more confused to go into a room or an area or a confrontation with another resident who also probably has some cognitive impairment or perhaps mental illness, traumatic brain injury, but they are not as cognitively impaired. So they try to stop or interfere with the resident who's more cognitively impaired, and then this results in an altercation or an incident. So you have the people who are independent, more cognitively impaired, going into the space or verbal space of someone who is cognitively impaired, but not as much. And then that person reacts to the initial person because their cognition isn't that they understand that person is very cognitively impaired. They understand that they're in their space, and so they react. So what you will also find is that verbal aggression is often associated with intact cognitive function, but delusions and affective disorders. So somebody might think that another resident is a relative and they get angry with them, or they might think that have a delusion that the person is stealing from them or has taken something from them. And so they might be more verbally aggressive with them. Hey, give that back to me. Hey, what are you doing here, Sister Mary? And so that can be a contributing factor. Or they might have depression or anxiety, and they're more anxious and they respond to people because of their anxiety. And of course, with anxiety also goes along irritability. Now, of course, we have to be very cognizant of people who may have schizophrenia or bipolar disorder, where they become manic, or bipolar disorder with psychosis, or perhaps paranoid schizophrenia. As I said before, we have a lot more people with these mental illnesses at younger ages who are more mobile, which, as we talked about before, lends itself to resident-on-resident aggression. And also, they might be younger and stronger, so they can be more physically aggressive towards people and hurt residents who are more frail and susceptible to injury. you have a lot of people who are in facilities now who have traumatic brain injuries, and they're younger than 65 years old. Traumatic brain injuries are very challenging to treat from a psychiatric standpoint. It's very difficult to control the delusions and the impulsiveness and the restlessness and the aggression in these folks. And once again, they're often younger and stronger and more mobile. And this combined with all these different characteristics of being stronger, younger, more mobile, that they might be more verbal and physically aggressive, and do more serious harm to elderly or impaired long-term care residents. So one thing to remember is that people who are depressed, have delusions, hallucinations, are more likely to have physically aggressive behavior. So I wanted to cover those things first and give you a chance to think about those and to look at your current population. And then also remember that you might have people who have had alcohol abuse, substance abuse, might have dementia related to those things, which also tends to lend itself with a dual diagnosis of some depression or anxiety disorder. And then they can also be more aggressive with other residents. So please keep these things in mind as you look at your current residents and see who might be a resident who is more likely to engage in resident-on-resident aggression, and also to help you understand when it does occur, why it's occurring. Thank you very much. We're going to end here, and we will start another video and further discuss this topic. My name is Randy Beckett. I appreciate your time. Thank you.